Hello, class. Today we are going to talk about injuries that affect the renal system. But don't worry, you're in good hands. Come on, that was funny. All right, let's go. Here are your course objectives, which are located in the student version of the PowerPoint. An acute kidney injury is a sudden reduction in kidney function, and this can occur over the span of hours to a few days. And this is going to disrupt homeostasis. It is going to prevent the kidneys from appropriately regulating fluid and electrolytes, as well as acid-base balance. So you will see a lot of electrolyte anomalies in these patients, such as hyperkalemia, hyperphosphatemia, hypocalcemia, and you will frequently see acid-base balance disruptions, such as metabolic acidosis. Now, an AKI will also reduce the kidney's ability to eliminate certain things from the body, such as medications. Also, it can reduce the body's ability to eliminate waste products, such as your creatinine or your urea, your blood, urea, nitrogen, your BUN. That's why we look at BUN and creatinine, because these are waste products. And we would expect these levels to be low. And since renal patients are unable to appropriately eliminate waste products from the body, these numbers are going to be elevated. Usually we use the word injury to describe permanent damage and a permanent loss of function of an organ or organ system. An AKI is going to be slightly different. An AKI may be 100% reversible with no long-term damage. A patient may experience a mild to moderate degree of damage and loss of function, or a patient may have an AKI and end up with end-stage renal disease. And this is going to be dependent on the cause of the AKI. Was damage done to the nephron? If so, how much? It will be influenced by the severity of the AKI and how quickly it was resolved. How promptly did we address the underlying cause? It will also be dependent on other comorbidities that the patient may have. Now, an AKI is going to be classified as a prerenal, which is the most reversible type of an AKI, and this is going to occur before the kidneys. You may also have an intrarenal AKI, which the problem is occurring inside the kidney. And this type of injury is the least reversible. Or you may have a post-renal injury, which is going to be caused by an obstruction of some sort that is going to cause a backflow of fluid into the kidneys, which can damage the nephrons. A prerenal AKI is going to be caused by conditions that lead to hypoperfusion. And the reason that this is the most reversible type of AKI, if we can restore perfusion before ischemia leads to injury, then no permanent damage will occur. Now we can expect that a prerenal AKI is going to be caused with conditions associated with hypoperfusion, such as shock, whether it's obstructive, cardiogenic, septic, hypovolemic. All of these types of shock lead to hypoperfusion. Other causes of a prerenal AKI can be severe heart failure, where your cardiac output is impaired. Hepatorenal syndrome, which we'll learn about in the next module. Infection. Renal artery stenosis or a thrombus formation in your renal artery. That is going to decrease the blood flow to your kidneys. Certain medications can lead to a reduced blood flow to the kidneys, and they can also cause damage to the actual nephrons. We know that hypoperfusion leads to ischemia, which will ultimately lead to injury if we do not treat the underlying mechanism and restore perfusion. Well, knowing that, I want you to understand that a prerenal AKI can ultimately progress into an intrarenal AKI if we do not restore perfusion before injury occurs. Now, an intrarenal AKI is the least reversible type of AKI because damage is going to be done to the nephron, the filtering unit of the kidney. Now, along with anything that can cause a prerenal injury that we don't promptly resolve, other causes of a intrarenal AKI can be any type of inflammatory disease such as lupus, polycystic kidney disease, infection, pyelonephritis. If you have an infection in your kidneys, that is going to lead to scarring and loss of nephron function. Other things like nephrotoxic drugs such as NSAIDs, certain antivirals. And this is actually kind of funny. So we use ACE inhibitors and ARBs in patients that have both hypertension and diabetes. They should be on either an ACE inhibitor or an ARB to protect their kidneys. But these medications can also cause an intrarenal AKI. They can actually cause damage to the nephron at the same time. The medication we're using to protect you, that's pretty ironic. Any type of illicit drugs such as cocaine. You may experience something like rhabdomyolysis, which can lead to acute tubular necrosis. Just like prerenal injuries can lead to intrarenal injuries, so can postrenal. For example, I had obstructive kidney stones in my UVJ, in my ureter. And the UVJ is just the smallest part. Well, that puts you at more risk for developing a UTI. Well, I developed a UTI, and since I had an obstruction, that bacteria went up into my kidney and caused some damage to my kidney. So, usually a post-renal AKI is going to be caused by some type of obstruction, like urinary calculi, like I had. Any type of BPH, because that is going to cause a backflow into the kidneys, which can cause hydronephrosis. And remember, blood is only supposed to flow one way. Anytime we have a backflow, we can damage the kidneys or any organ for that. Cervical cancer, any type of stricture. If you have cystitis, that can ultimately lead to an AKI, especially if you have a stone or some type of obstruction present. Now, this may or may not be reversible depending on if that backflow was enough to cause damage to the nephron. And in my case, it did. There are many risk factors associated with AKIs. There's many conditions or diseases that put patients at risk for the different types of AKIs. For example, hemorrhage, hypovolemia, shock, heart failure, liver failure, all place the patient at risk for a pre-renal AKI. Things such as rhabdomyolysis, pyelonephritis. Certain medications can put the patient at risk for an intrarenal AKI, and things such as BPH, bladder cancers, and any type of obstruction will put the patient at risk for a post-renal AKI. Now, I don't expect you to memorize all these medications, but I just want you to be aware that there's many medications out there that can lead to an AKI. Some medications are only going to cause a prerenal injury because they reduce the blood flow to the kidneys. Other medications can actually damage the nephron itself. Meanwhile, some medications can even cause a post-renal injury. Now, some medications like statins and illicit drugs can cause rhabdomyolysis, which can lead to acute tubular necrosis, a prerenal injury. And even crazier, some medications can cause like multiple types of injuries, like NSAIDs. They're cyanide. I'd rather drink cyanide. But they can cause a prerenal injury. They can cause a intrarenal injury. Acute tubular necrosis can sometimes be difficult to understand, but all it is damage that occurs that leads to necrosis in the kidney's tubules. And this can be caused by prerenal injuries, intrarenal injuries, and postrenal injuries. So what's happening is there's going to be that damage to the capillaries of these tubules, and that is going to cause necrosis and apoptosis, where the cells are going to have that programmed cellular death. And then these cells are going to start shedding off. And these patients are going to have very, very dark urine, and you're going to see cast in them. But this is what occurs when a potential reversible injury starts to leave that spectrum of being reversible and start heading towards the irreversible. This is why a lot of AKIs become permanent damage or end-stage renal. Acute tubular necrosis can be categorized as an ischemic-induced injury, and that's going to be your prerenal causes, like your hypotension, your hypovolemia, your shock. Ultimately, the ischemia is going to lead to the necrosis. ATN can also be classified as nephrotoxic induced, and that is going to be caused by those nephrotoxic agents, such as your NSAIDs, your aminoglycosides, things like that. Because what these drugs are going to do is they can release toxins into the kidneys, which is going to cause damage to that nephron and ultimately leading to the same thing: damage, hypoxia, necrosis, apoptosis. You can also have sepsis-induced ATN, and this is going to be caused by things such as hypotension and renal hypoperfusion, and all of those catecholamines that we are going to start releasing when our body starts to go into that shock. And and those inflammatory cytokines. Remember that massive systemic dysregulated inflammatory response. That is going to cause damage to the tubules, which is going to lead to necrosis, apoptosis. So as you can see, regardless of the actual etiology, it's going to result in the same thing. Now, ATN can be reversible if you treat the underlying cause promptly, very promptly, and if you provide supportive care to the patient. Make sure that they are having adequate volume and that you will give these patients large amount of fluids because you want to prevent any further damage. An AKI is going to be divided into 3 distinct phases. And unlike shock and other conditions, you want your patient to progress through these phases because these phases are going to illustrate increased function and recovery. Your first phase of an AKI is going to be your oliguric phase, and this is going to be the phase you're probably most familiar with. And this is going to be categorized by oliguria. You'll often see less than 30 milliliters an hour, less than 400 milliliters a day, although it is best to calculate adequate urine output by 0.5 milliliters per kilogram per hour. However, if your patient isn't severely obese or very underweight, generally the 400 a day or the 30 milliliters an hour will suffice. Now, this stage of an AKI, you're going to have an elevated BUN and creatinine. You're going to expect to see hyperkalemia, hyperphosphatemia, hyponatremia. You would expect metabolic acidosis because you're not eliminating those acids and reabsorbing that bicarb appropriately, and your patient is likely going to be very fatigued. You may also show signs of fluid overload because you're not eliminating fluids from the body. Now, your diuretic phase, your clinical manifestations are going to be a little different. And this phase is marked by increased urine output. And actually, you can start autodiuresing. So you can actually have significant urine output, anywhere from 3 liters to 5 liters a day. That is because your kidneys are starting to regain their filtering capabilities. So they kind of go into overload. Now, you will often see signs of dehydration or hypovolemia. And this is going to be the exact opposite. You may see hypernatremia and hypokalemia because your kidneys are going into overdrive. You're getting rid of all this fluid and potassium, causing you to have like a relative increase in your sodium because the fluid's gone. It's not real, but because you have such low blood volume, it's going to make this sodium levels higher in relation to the fluid. You may see hypotension, right? You're eliminating all this fluid, your intravascular volume. You will see that your BUN and creatinine will slowly start to trend down, getting closer to normal. Now, your recovery phase is going to begin when things just start to normalize. Your kidney function goes back to baseline. You'll see that your BUN and creatinine, they're definitely going to be normal. And in some cases, they may show up even a little lower than normal. And you'll notice that your GFR is going to start returning to baseline. Your GFR is going to give us the best and most complete picture of your kidney function over time. So you will see that in patients with kidney disease, like CKD, that they trend the GFR to kind of see the progression of this disease. However, inpatient is a little different. We tend to focus more on the creatinine, and that's because creatinine is a waste product. I want to see how well the kidneys are doing their job. How well are they eliminating waste from the body? Now, we know that we use creatine to help us in muscle building. Well, the byproduct of that is creatinine, and it's a waste product. So we expect our kidneys to eliminate it and that number to be very low because our kidneys are doing their job. Well, in an AKI, you can expect that the creatinine is going to be elevated because we are not able to eliminate this waste product. You will also expect the GFR to be decreased. Now, your BUN is going to be like the myoglobin of the heart. It's not very specific. There's many conditions that are going to cause an elevated BUN, and they have nothing to do with the kidneys. Now, if you have an AKI, your BUN will be elevated. So will your creatinine, which is what we're going to look at. But if you see an elevated BUN, but the creatinine's normal, the GFR is normal, that's not a kidney problem. And the kidneys are not affected. You will also see alterations in your electrolytes. And obviously, when you're in the oliguric phase of an AKI, your urine output is going to be decreased, and your kidneys are not excreting potassium appropriately. And of all the electrolytes here, potassium will kill you the fastest, so that's going to be the most important. Hyperkalemia is going to lead to life-threatening arrhythmias and ultimately cardiac arrest. So you would expect someone with an AKI to have elevated potassium, and they are unable to appropriately filter out phosphorus as well. So a lot of times they'll have hyperphosphatemia, and this you'll see is much more frequent, especially in patients with CKD. Their phosphorus can be like crazy high, like greater than 10, and they're just fine. But with an AKI, anything acute, you definitely want to address it a little more promptly. But remember, phosphorus and calcium have that inverse relationship. So a lot of times if your phosphorus is elevated, you're going to have hypocalcemia. Plus, patients with injury to their kidney, they're going to have protein loss. And I'm going to tell you, 90% of your calcium in your body is going to be bound to albumin. So if you see that the patient has a low serum albumin, you can't trust the calcium level. You need to do an ionized or a corrected calcium. I just wanted to throw that out there. Now, we know that erythropoietin is made in the kidneys, right? And that is going to be your red blood cell producing. Well, patients that have kidney impairment, they're going to have a reduction in the excretion of erythropoietin. So a lot of times that can lead to things such as an elevated hemoglobin, elevated hematocrit. Now, with your urinalysis, especially if you have like a intrarenal injury, you're going to definitely see like red blood cells and cast. And on your ABG, you would expect to see metabolic acidosis. And that is because your body is having trouble eliminating certain acids from the body, such as pyruvate, lactate. You will also see that they are going to increase their ammonium, which has that acid-like property. And then you'll see that there's going to be a dysregulation in the ability to reabsorb bicarbonate, which is going to be your nutrient. neutralizer. So you will commonly see metabolic acidosis in this group. We are going to treat a pre-renal AKI different than we do a intrarenal AKI. So it's important to determine the cause of the AKI and if this is a pre-renal or intrarenal injury. And we're going to do a series of tests to help us determine that. Now, I said your BUN was important in helping us determine if it was pre-renal or intrarenal. Here's an example. Pretend your creatinine is 2, but your BUN is 40. That's going to be a difference of 38. So likely you have a pre-renal injury because that ratio will be greater than 20. But if your BUN is 10 and your creatinine is 2, it is likely going to be an intrarenal injury because that difference is 8, which is less than 20. You may also see the provider order urine electrolytes, your urine creatinine, urine osmolality test, and that again is going to help us see if this is pre-renal or intrarenal so that we can make sure we're doing the appropriate interventions. Although we are going to use your creatinine and your GFR as your diagnostic tools in diagnosing an AKI, we're going to use various other tools to help us in diagnosing an AKI and monitoring its progression. Think about it. We may use various tools to find the underlying cause, to monitor for worsening AKI, or to assess for any potential complications that can arise from an AKI. You may see a urine culture ordered, and that could be, did an infection lead to this? Did the patient become uroseptic, and did this cause pyelonephritis, or was this a pre-renal injury caused by an infection? We're going to trend the patient's CBC because we know that anemia is going to be associated with an AKI, since an AKI is going to hinder the patient's ability to secrete and produce erythropoietin. They may do a renal ultrasound looking for the cause of this AKI. Do we have an obstruction? A CT scan can also identify obstructions. They may do a renal biopsy, and that can show you absolute differentiation between an AKI and a CKD, but I don't think I've ever actually seen a renal biopsy done unless they suspected cancer, just because it's so invasive. They may do other radiographic studies to look at the size of the kidney. Look, you can sometimes see kidney stones in x-rays and whatnot. They may also do a urinalysis. Are there cell cast in there? That's going to indicate the patient is in acute tubular necrosis. Is there proteinuria, which I'm sure there is? Is there red blood cells in there? What's the specific gravity? I am going to talk about more pharmacology associated with renal failure later on in the lecture, but I just wanted to talk about fluid administration and diuretics here because these are going to be specific to AKIs. Remember, our goal of an AKI is to treat the underlying cause, prevent any further damage. Now, if you have a pre-renal injury, we want to make sure that you have that preload, that volume, so that you can adequately perfuse the kidneys and hopefully stop and prevent any further damage. So we might give you fluids if applicable. Now, would we give someone who has really poor cardiac output, would we give them fluid? No, we would probably give them an inotrope. But you have to think about the cause and if this treatment is appropriate. But most of the time, fluids will be appropriate. We may give them colloids such as albumin if we need to expand volume. We'll do that often in like patients with severe hepatic dysfunction or patients with very low albumin or who are very malnourished. Now, our goal is to increase that renal perfusion. Or if a patient is having excessive loss, or if they're in the phase of the AKI where they have that autodiuresis, then we just want to maintain that perfusion. Now, we may also try diuretics if that fails. And the goal of that is just to jumpstart the kidneys. Hey, I want you to produce me some urine. And a lot of times we will use loop diuretics, such as Lasix or Bumex. Generally in the ICU, we're going to use Bumex. It is 40 times more potent than Lasix. But these are our two options before we have to move on to dialysis. Now, the reason I separated this, again, is because this is not appropriate for CKD patients because they are dealing with a chronic and a progressive disorder. At this point, the only way to prevent CKD from progressing even further is supportive therapy, like keeping blood sugar under control. If hyperglycemia is a contributing cause, keeping blood pressure under control. But once a patient results in end-stage renal, we would no longer do these therapies. But remember, an acute kidney injury is an acute process. So we don't know if the kidneys are going to work again. So when a patient goes into an AKI, you never know how this is going to turn out. Only time will tell you. And it takes months for, pretend I had an AKI, right? And it progressed to end-stage renal. You have to wait a certain amount of time before you can actually make that diagnosis. So that's why these treatments are only relevant to AKIs. This would be a good time for you to get a snack and take a break, like I'm about to do. I want you to be able to tell the differences between an AKI and CKD. With an AKI, you're going to have that sudden and abrupt loss of kidney function. So often, the patient's clinical presentation is going to be much more severe. Acute is generally going to be more severe than chronic because the body has time to compensate for those chronic illnesses. Now remember, the AKI is potentially reversible, and the treatment is going to be very focused on the cause of the AKI. So treat the underlying cause and support the body. We often have to use fluids and or diuretic use. Now, if an AKI is persistent or if the patient is showing clinical manifestations of significant uremia, respiratory or circulatory compromise, electrolyte imbalance, then dialysis may be required. Now, this may not be permanent. It just depends on if the kidneys are going to regain their function. Now, with chronic kidney disease, this is going to be a gradual loss of kidney function. It is going to occur over a span of years, and initially, patients aren't going to show many symptoms until it progresses to more advanced CKD. Now, patients may present with some non-specific symptoms that, they don't really think much into. Obviously, CKD, unlike an AKI, cannot be reversed. Now, there's a lot of things and treatments that are recommended to slow down the progression of CKD, such as diet modifications, blood pressure control, strict glucose control, and eventually, as the patient progresses to stage 5 or end-stage renal, they will require dialysis to maintain life. In the United States, over 35 million people have CKD. And unlike an AKI, which may or may not be reversible, CKD is characterized by a chronic and progressive damage to the entire nephron unit. It can be caused by various neuropathies that are going to cause scarring and fibrosis to the kidney, resulting in a gradual loss of function. Now, I would like to mention that you can have an AKI when you have CKD. That's going to be called like acute on chronic renal failure. And in this type of AKI combined with CKD, patients are going to be at increased risk for negative outcomes. Causes of chronic kidney disease are going to be most commonly diabetes, followed by hypertension. But atherosclerosis, chronic anemia, sickle cell, any type of coagulopathy, heart or liver failure, illicit drug use, nephrotoxic agents such as chronic NSAID use, alcohol abuse, and as well as smoking. I would like to say this is very interesting. So for our ACE and ARBs, what ACE and ARBs do are going to prevent the RAS system from activating, which can actually worsen kidney disease. So that is why every patient that has hypertension and diabetes is going to be recommended to be on an ACE or an ARB, and they are first-line antihypertensives. But at the same time, an ACE and an ARB can actually be nephrotoxic. So the medication we're giving you to protect your kidneys can cause you to go into renal failure. And all patients with CKD should be on an ACE or an ARB. But if you go into an AKI or when you progress to end-stage renal, then ACEs and ARBs will be discontinued. I just wanted to throw that out there because it's insane. Now, complications of CKD are going to be end-stage renal failure that is going to require either dialysis or a transplant. Increased morbidity and mortality rates are going to be seen in patients with CKD. It ultimately is going to decrease the lifespan and lead to dysfunction in other organ systems such as liver and heart failure. Now, once a patient progresses to end-stage renal disease and they require dialysis, the average life expectancy is only about 5 to 10 years. And that is going to be an average. So that's going to be very highly dependent on the patient's age, the addition of any comorbidities. For example, a person in their 20s who's diagnosed with CKD that reaches end-stage renal is going to they may live up to 20 years. Meanwhile, someone in their 70s or 80s may only live up to 1 to 2 years. And lifestyle choices do play a major role on the progression of CKD. In fact, those patients requiring dialysis, patients that do not have diabetes, actually have a much better survival rate beyond 1, 3, and 5 years. CKD is divided into 5 distinct stages, and CKD is staged based off of your GFR. And there's various tools out there that estimate your GFR. They utilize things such as your weight, age, serum creatinine, and other factors. If your GFR is above 90 but not quite normal, and you have a sign of structural kind of anomaly, such as fibrosis or scarring, then you have CKD stage 1. A lot of times, CKD is not going to be picked up on because they use the estimated GFR, and it would be like GFR greater than 60. So a lot of that time, it will not be picked up until stage 3 on your lab work. And even then, you may have minimal to no symptoms. And stage 3 is going to be divided into stage 3A and 3B. Now, when you start that is where you can start having more symptoms related to renal failure. And at that point, your GFR is anywhere from like 29 to 15%. And some patients are even going to require dialysis during this stage, depending on their serum electrolytes and other factors. Now, stage 5 is going to be characterized by end-stage renal disease. And patients will need dialysis, a transplant, or they will die very quickly. Because remember, dialysis is going to be working as the kidney. Now, when we hear those frequent signs of CKD or like renal failure, they're usually talking about stage 4 to 5 of kidney failure. That's where you're going to have like the fluid overload, the fatigue, the hypocalcemia, and the other electrolyte imbalances. You may develop uremia. Your serum creatinine is going to be significantly higher, anywhere from like 2, 3, and so on. So usually when we're talking about like signs and symptoms of kidney disease, this is the area that we are specifically referring to. Now, clinical manifestations of renal failure are going to be determined by the onset of the renal failure. Was it acute? Was it chronic? Because often patients with CKD are just going to have that very non-specific symptoms until they go into end-stage renal. With acute renal failure, often you will see a sudden onset with more severe symptoms. It is important that you understand that assessing for an AKI or CKD is going to go well beyond just doing a renal assessment, because your kidneys play such an important role in homeostasis that dysfunction in them can alter multiple organ systems and lead to life-threatening complications such as uremia. And it is important that you understand the clinical manifestations of uremic encephalopathy. You'll see a bunch of neurological changes such as lethargy, seizures. You may see signs of metabolic acidosis. You may notice uremic froth, which is going to be there's so much urea in the body that it is going to start crystallizing on the skin. Those drugs are going to be excreted primarily or solely through the kidneys. So patients with renal impairment are going to take much longer to eliminate these medications from their system. So you can expect the half-life and plasma levels of these medications to be increased. And this can be especially challenging in medications that have a very narrow therapeutic range, such as vancomycin, phenytoin, where there's a thin line between therapeutic and toxic. But you may see the doses of these medications adjusted for renal impairment. So the GFR, creatinine clearance, whatever system they use, they will calculate this and decrease the dose, its frequency, based on how long they estimate the patient to eliminate these drugs from their system based on their GFR. Now, this is not a perfect system because other factors play a role in drug metabolism. But this helps prevent drug accumulation and drug toxicity in renal patients. And you'll see that certain medications are just going to be contraindicated in patients with severe renal impairment. You'll see, for example, if a patient is receiving Lovenox for DVT prophylaxis, if they're receiving therapeutic Lovenox for an MI or a DVT, pulmonary embolus, you'll see that if their creatinine clearance drops below 30, that this will be discontinued and another anticoagulant will be started, such as heparin. Lovenox in itself has a very long half-life and it's eliminated solely through the kidneys. So if a patient has severe renal impairment, they're going to take much longer to eliminate this drug. And then we keep giving dose after dose, and it's going to cause supratherapeutic levels of an anticoagulant, putting the patient at risk for severe hemorrhage and other bleeding risks. Now, drugs that are highly protein bound are going to cause toxicity at much lower doses. Think about it. Should you have protein in your urine? Absolutely not. People that have protein in their urine have damage to their kidney, whether it's CKD and AKI. When we have damage to our nephron, we lose our ability to appropriately filter and reabsorb molecules like protein. So you will see proteinuria in these patients. So because of this, their plasma protein levels will be decreased, preventing these drugs from appropriately binding to protein and causing drug accumulation in the system. So you need to be aware of that as well. Now, I want you to also be aware that some drugs will be affected by dialysis. Drugs that are highly water soluble, highly protein bound, will be affected by dialysis, while other medications not so much. Certain antibiotics such as cefepime, vancomycin will have to be adjusted based on the patient's dialysis schedule. Meanwhile, you'll have drugs such as, let me think of one, Rocephin or deoxycycline are not eliminated through dialysis, so you don't have to change the time or dose based on the patient's dialysis schedule. And this is something that's going to take you quite a long time to kind of fully become comfortable with working in the clinical setting. It takes time to know which drugs are going to be dialysable and which are not. And it will come with time, I promise. Now, other medications that you may see given in an AKI and CKD may be various phosphate binders like sevelamer. And now this phosphate binder is going to be more optimal for patients who do not have hypocalcemia or whose calcium levels are on the higher side, because this is not going to increase their serum calcium. You may also see calcium carbonate or calcium acetate given, and this is going to be ideal for patients who have hypocalcemia because it is going to bind to the phosphorus as well as help raise serum calcium levels. And aluminum hydroxide can also do the same thing. You may also see like iron supplements such as iron, sucrose, and erythropoietin given. Remember, our kidneys produce erythropoietin to help trigger the production of red blood cells. And when they're under any type of injury, that is going to reduce, and you will see signs and symptoms of anemia. And we will also give folic acid, especially when a patient's receiving dialysis, because that's a water soluble vitamin. So we're going to be dialyzing it, and it is an important vitamin in anemia treatment. You will also see anticoagulants given, as well as we're going to heparin lock dialysis catheters in patients who have a lot of clotting tendencies with their dialysis catheter, may have a heparin drip running. Of all your electrolyte anomalies, imbalances in potassium are the most immediately life-threatening. And of those imbalances, hyperkalemia is going to be the most dangerous. Normally, we eliminate our excess potassium through our renal system. Now, patients with advanced CKD and patients with an AKI, they are not going to have the ability to adequately remove this potassium, so they are at high risk for the development of hyperkalemia. Now, signs and symptoms of hyperkalemia, you should always just put those into memory. Muscle weakness, muscle tingling. You can have respiratory depression in more advanced hyperkalemia. You may see EKG changes as well with the peak T waves, the prolonged QR interval, and eventually your P waves are going to flatten and slowly disappear right before your patient goes into cardiac arrest. So we need to know how to promptly recognize and treat hyperkalemia. Now, you may see things like K-exalate, Lokelma used, and that's going to be usually in the less serious forms of hyperkalemia. When you have significant hyperkalemia, you need to use insulin and dextrose 50. We give insulin because insulin is going to cause potassium to drive into the cell from your extracellular space, ultimately reducing your plasma potassium levels. Now, dextrose 50, wait, that's a hypertonic solution. What? That pulls yeah, no, don't overthink it. For one, when we give you dextrose 50, what we are doing is we are raising your serum glucose, and that can help you produce even more insulin to drive more potassium into the cell. Plus, we don't want to bottom you out giving you IV insulin. Now, you'll often see like calcium gluconate or calcium chloride given, and that actually doesn't do anything to normalize your hyperkalemia. We do that as a cardiac protective agent. It is going to help protect your heart from the life threatening dysrhythmias associated with hyperkalemia. Because, trust me, you want to address this quickly. Now, you may see us give loop diuretics. This is only going to be relevant in patients that are not in end stage renal because, or our AKI patients, because, some progressive CKD stage 5, we're not going to give that patient diuretics. Now, we also sometimes give sodium bicarbonate. And this is not a set in stone, but it is something to kind of keep in the back of your mind. Roughly for every 0.1 our pH is going to reduce, our serum potassium is going to increase by 0.6 milliequivalents. So often these patients are going to have metabolic acidosis, which is going to further worsen the hyperkalemia. So we definitely want to treat, well, you want to treat metabolic acidosis anyways. But in this case, you definitely want to promptly treat it so that you're not going to worsen the hyperkalemia. So a lot of times you'll see sodium bicarb given. I want you to understand that even if a patient's GFR is low and their serum creatinine is high, that is not necessarily an indication for dialysis. Now, we know that patients who regress onto CKD stage 5, they are going to need dialysis. But this is going to be more focused around an AKI a lot of times because we will have patients with a creatinine of 5, but we are going to continue to try to jumpstart those kidneys. And if you're not showing signs of fluid overload or electrolyte disturbances, metabolic acidosis, uremic encephalopathy, we are not going to start dialysis. Even if you're oliguric, if your electrolytes are within range, we're going to keep trying to jumpstart those kidneys. Now, you will see dialysis started early, especially in like toxic encephalopathy. That is like your drug overdoses or in cases of cerebral edema, metabolic acidosis, and obviously hyperkalemia. If your phosphorus or something is just high, I mean, it's not that urgent. Now, dialysis uses your dialysis fluid as a concentration gradient, and this is going to act as a semi-permeable membrane and filter the kidneys through diffusion and osmosis. The most common type of dialysis, and the one you're probably most familiar with, is hemodialysis. And this is usually done in the hospital or at a facility, although it can be done at home if someone is trained. But you don't see that very often. And in this type of dialysis, it is going to be done quickly. Most of the time, patients are going to have fluid removed, but sometimes they can receive hemodialysis just to act as a filtering agent to help eliminate the waste from the body. And that's going to be in your patients who don't necessarily have that fluid overload yet. But most of the time, they're going to be taking off anywhere from like 1 to 5 liters within a 4-hour period. So think about the possible complications with that, especially with their blood pressure dropping. Now, there's various different types of accesses for dialysis. You may see a perm cath, and that is just a tunneled catheter that can be used on a longer term basis for dialysis. And I'm not going to go into that heavily since we already talked about central lines. But one of the biggest risks with these are going to be your risk of infection and clotting off. And these types of accesses are not as compatible with dialysis. You can run into flow problems and whatnot. So, these, although they're long term, they generally want to kind of move away from this. A lot of times you'll see these in place for people who don't have fistula availability in their arms, like their vessels. You're unable to make that connection between the artery and vein. So people with like multivessel disease, who've had like cancer of the lymph nodes, things like that. But a lot of times you'll see someone with a perm cath and an AV fistula. And that is because a fistula takes time to mature. So they may use the perm cath until that fistula actually matures. You may see a AV graft, which you don't see very often. And that's just going to use some type of artificial vessel, like a pig vessel. And it is going to attach to the vein and adjacent artery to create an access. But this one is going to be available to use almost immediately, unlike your fistula. If a patient has an AV graft, it's important that when the dialysis is discontinued, that you hold significant pressure to stop the bleeding. And patients need to know not to use that arm to carry objects. You don't want to put a blood pressure cuff on it. And this type of access is going to cause a major risk of infection, clotting, or bleeding. Now, your AV fistula, that's going to be your goal for dialysis. You're going to use it. It's going to be inserted by anastomosis of a client's vein to that adjacent artery, and it's going to create a pseudoaneurysm that is going to allow for dialysis. Now remember, this is going to take time for it to mature, so they're going to have some type of access, alternate access, if they need dialysis right now. Now, some things with the AV fistula, they must exercise appropriately for it to mature, so they need to move their arm. This is going to be at risk for bleeding. And you need to be aware of signs of infection, which, you'll see localized signs of infection like the redness, swelling. Now, it's important to monitor for the bruit and thrill. And it is important that you, as the nurse, educate the client and that you are aware of the differences. So remember, you're going to hear a bruit and feel a thrill. The bruit is going to sound like this whooshing sound, and that occurs from the narrowing of the artery that they did to create the fistula. And your thrill is going to be a very rapid vibration. Now, aside from your infection, bleeding, clotting, there are some other potential fistula or graft issues. One of them is going to be your ischemic steel syndrome. And this is going to be characterized by ischemia of the hand. And it's caused by reduction of blood flow through the arterial segment distal to the fistula and can lead to loss of a limb if not promptly addressed. So it is important that you do your neurovascular assessments, that you look at those 5Ps. Another thing you do is you do the Allen's test, and that will help determine if you have blood flow peripheral to that fistula. which is usually in the arm. Another risk factor is going to be your dialysis equilibrium syndrome. And in that, a patient will develop a variety of neurological manifestations that will be seen during or after dialysis, especially when the patient just starts beginning dialysis. And this syndrome is going to arise from fluid shifts that occur because of hemodialysis, and it is going to lead to cerebral edema. Peritoneal dialysis is going to be administered by inserting a catheter into the abdomen, into the peritoneal cavity. And you are going to administer the dialysate, which will work as that concentration gradient, and fluid will collect in the peritoneal cavity. This is going to be done several times a day, and the patient can do this at home. Unfortunately, there's not much like education around this, and it's not done as frequently as it could, which could help patients with a better quality of life. Plus, a lot of patients are going to have multiple comorbidities, which will prevent them from receiving this type of dialysis. Contraindications to this type of dialysis will be like multiple abdominal surgeries, which is going to cause some type of scarring in the abdomen or peritoneal cavity, adhesions from severe endometriosis or surgeries, patients with severe liver failure who may have ascites. So that would also include patients with right-sided heart failure, patients who have developed peritonitis previously, patients with like tumors or other anomalies that will prevent the catheter from being placed in the abdomen. Now, for this type of dialysis, the highest risk is going to be risk of infection, peritonitis, which can lead to sepsis, shock, multi-organ failure, and death. Now, remember your signs of peritonitis. That's going to be that severe abdominal pain that gets worse anytime there's any type of activity, severe nausea and vomiting, fever, a distended abdomen, a collection of fluid or pus in the abdomen, constipation, not having any gas, signs of an AKI, extreme thirst, and whatnot. So it's very important to educate the patient about the sterility that is needed to receive this type of dialysis. Now, continuous renal replacement therapy, or CRRT, is a very slow and mild form of dialysis. And this is going to be reserved for patients who are hemodynamically unstable, who cannot tolerate hemodialysis. So patients who are on multiple vasopressors or require a high dose of a vasopressor, patients who are in severe septic shock, multi-organ failure, patients with cerebral edema. So if a patient gets cerebral edema from hemodialysis, we can administer this therapy, which does not cause the type of fluid shifts that hemodialysis does. So this would be your treatment. Now, this type of dialysis requires ICU level of care, and it's going to be performed by an ICU nurse. And level of care is supposed to be 1-to-1. The nurse will do dialysis. She will also frequently trend labs every 4 hours, and she will have a standing order to administer electrolytes based on the patient's serum, potassium, phosphorus, magnesium. Many causes of renal failure in children actually can begin occurring during fetal development. One of those is going to be your autosomal recessive polycystic kidney disease. And this is a genetic disorder that affects about 1 in 20,000 children. And it is going to cause fluid-filled cysts to develop on the kidneys. And this can cause the kidneys to enlarge. It can lead to hydronephrosis, which can ultimately lead to a decline in renal function and lead to renal failure. Potter syndrome is a very rare condition, and it's going to affect the growth and function of the fetus's kidneys and other internal organs. Now, there's many causes for this condition, but ultimately the symptoms are going to arise because it is going to be associated with too little amniotic fluid in the uterus. And babies born with this disease are going to have a very short lifespan. Now, ROH is another condition in which there is too little amniotic fluid, and this can lead to birth defects, malformations in the urinary tract, premature rupture of the membranes, poor fetal growth, and it can actually lead to issues with lung development to where the baby is not going to appropriately develop their lungs. Now, with pediatrics, other causes can be a streptococcal infection. This can cause things like glomerulonephritis and other sequelae that can lead to inflammation in the kidneys. Children may experience like acute hemolytic reactions, which will ultimately lead to some degree of kidney impairment if it is not addressed appropriately. CKD, children can develop this as well, especially if they've had like frequent pyelonephritis, or if they have syndromes in where they will have a backflow of blood back into the kidneys. A backflow of blood is never good. And certain conditions can lead to acute renal failure in children, same as they can in adults. When it comes to CKD and end-stage renal and pregnancy, there are many things that you need to consider. If a woman has CKD but has not progressed to end-stage renal, if she becomes pregnant, she may rapidly progress to end-stage renal. And if she has end-stage renal already, she may require increased frequency of dialysis. And pregnancy in its own changes the physiology of the body. And this can actually worsen the severity of kidney function in women who have renal failure. And a lot of times, women with end-stage renal are going to experience fertility issues, and many may even become sterile. Now, if a woman can successfully get pregnant, she is going to be at risk for a lot of complications associated with pregnancy, such as preterm labor, preeclampsia. The neonate may be small for gestational age, and there is an increased risk for neonatal death. So it is very important that the kidney failure is addressed and comorbidities are promptly treated, such as strict management of hypertension and ensuring that maternal serum albumin and hemoglobin are within normal range. Nutrition related to CKD and end stage renal is actually pretty complicated. It is going to be highly dependent on the stage of CKD, the individual needs, whether they are receiving dialysis or not, and what type of dialysis they are receiving. Because patients with peritoneal dialysis are not going to have as much dietary restrictions. Now, with stage 1 and 2, your diet can relatively stay the same. You just want to reduce sodium, fat. You want to increase water intake, calcium intake, as well as magnesium intake. Now, when you get into like stage 3, that is where the patient is going to need to make some more significant changes to their diet. They need to adhere to a heart healthy diet, a renal diet, and at this point, they are going to need to reduce their protein intake. Wait, Kat, I thought you said that, patients with CKD are going to have low protein. Why are we going to have them reduce their protein and further cause low serum protein? Well, the thing is, with protein, it is very hard for our kidneys to filter. It's going to increase their workload. So, although patients are going to be protein wasting through the urine, unfortunately, giving them more protein, they're still going to waste the protein and they're going to put additional stress on their kidneys. Now, phosphorus is also foods that are higher in phosphorus, such as milk, oatmeal, and dark colored soda. They need to limit these as well because phosphorus can be quite very similar to how protein is on the kidneys. And patients at this stage of CKD are going to be more at risk for hyperphosphatemia. Patients are also going to need to restrict their potassium. Now, if they don't have any edema or heart failure, these patients should still increase their fluid intake so they can further dilute their urine and decrease the workload of the kidneys. Now, obviously, at this point, if they have heart failure, signs of fluid overload, you definitely want to start restricting fluid. Now, it's important to teach patients to avoid salt substitutes, or if they are going to utilize these, that they need to be able to read and understand nutritional labels because many salt substitutes are going to be made with potassium. And these patients are already going to be at increased risk for hyperkalemia. So they need to generally follow a low potassium, low phosphorus diet, as well as the low protein. And as they progress into end stage renal, they need to restrict their fluid, Generally, it's going to be anywhere from like a liter to a liter and a half a day. This is going to be individualized based on the patient. Now, when a patient starts receiving dialysis, their nutrition requirements are going to change a little. You may increase the protein intake, you may need to increase the phosphorus. Now, I'm not saying like go crazy with it, but I'm saying that you don't have to have such heavily restrictions. And you need to be aware of foods that are going to be high in potassium. Everyone thinks bananas, but there are foods with much higher levels of potassium that people are not aware of, like sweet potatoes, oranges, mangoes, avocados, regular potatoes as well. And you need to make sure that you understand this so that you can educate your patient. With your renal patients, you're going to see manifestations of renal dysfunction throughout the body. So don't get hyper focused on just the renal system because this is going to affect multiple systems throughout the body. So always think about your ABCs. Look for signs of fluid overload, such as edema, shortness of breath, hypoxia. You need to auscultate those lung sounds. Do you hear crackles? Because think about it, fluid overload, which is a circulatory problem, can turn into a respiratory problem very quickly, right? Think about it. We have all of this extra fluid in our vascular space, and it's going to start leaking out through the capillaries right into that lung tissue. And now you have non cardiogenic pulmonary edema. And now you have A, B, and C problem. So you definitely want to look for signs early on so you're not chasing the problem. And these problems can be very difficult to treat, with our AKI patients, we may try diuretics if they are showing signs of fluid overload, but that's not going to work with your CKD patient. If your fluid overload is significant, that it's causing circulatory or respiratory compromise, you're going to receive dialysis. And that doesn't matter if you have an AKI or CKD. But with CKD and end-stage renal, like that's going to be your only option. You need to look for things such as hypertension. Because remember, renal dysfunction can lead to hypertension because we're going to have problems with that renin-angiotensin system. Or even more importantly, we need to look for signs of hypotension, especially after dialysis. These patients love to become hypotensive during dialysis and after. You ever hear like those rapid responses? Hemodialysis, yeah, that's because these patients become extremely hypotensive. We're removing fluid from the vascular space, and then you're going to have additional fluid shifts, and it can be actually very, very complicated, and patients can become hemodynamically unstable very quickly. And you have to think about things such as orthostatic hypotension. You no longer have that compensatory mechanism going on, and they can become hypotensive when sitting up. And renal patients, it's funny, they're going to be at risk for bleeding and at risk for clotting. So you got to think about your DVT prophylaxis. You don't want them to get a DVT and to get a PE because, again, now you have a respiratory problem. So remember, with these patients, are you going to use Lovenox? No, 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 no. You are going to use heparin, sub-Q heparin, usually like TID, or it's every 8 hours, not TID. Then you need to watch for those rhythm changes, those tall peak waves, that widening QRS. You need to look for signs of ventricular irritation, such as PVCs, because that could I want you to always think when you have that type of patient going on, What's their potassium? Because that will kill you very, very quickly. I actually put like severe hyperkalemia up there right next to my A. Okay, because I mean it will kill you. So then you need to be monitoring the patient's labs. You need to be aware of the patient's labs. And you can't always just look at the numbers. Don't treat the number, treat the patient. These patients, for example, with the phosphorus, they generally have higher phosphorus levels. I'm not saying don't treat the phosphorus, but you need to trend those labs. Look at their trends. Is there any major changes? Just remember, just like your COPD patients who live in a state where they have more carbon dioxide going on, these patients may have higher baseline labs, so you need to consider that. You need to do strict I's and O's because remember, how much they remove from dialysis is based on the patient's intake. So it's very important. And you also need to look at more than just the amount. I mean, a lot of these patients, you may not have any urine. They may be anuric. But you will see, especially with AKI patients that are oliguric, that have little output, if they have like electrolyte imbalances or any type of like signs of severe volume overload, they will still receive dialysis, even if they are urinating some. Or here's an example, patients that have like hyperkalemia and we've treated it over and over again and your potassium's still 6.5, guess what? You are getting dialysis because you are going to die if you don't. Now you also need to look at the color of the urine, the odor. Could there be an infection? Why is this urine tea colored? That could be your ATN going on, rhabdo. You need to look at the clarity. Do you see urine cast in there? Do you see something that appears to be purulent? Do you see sediment? And then always them daily weights. Because for every kilogram of weight that a patient gains over the day, we need to assume that that is 1 liter of retained fluid. So, for example, if your patient is 3 kilograms above their weight yesterday, then they might have some extra fluid, maybe around 3 liters going on. So, it's very important that you are aware of that and that you use the same scale or the same method for weighing the patient. You don't want to use like 6 different scales if possible. And you need to teach patients about that as well. And to like weigh generally at the same time of the day if possible. With the same type of clothing. You don't want to have, your whole jogger outfit with an extra jacket, your gloves and hat on. Of course you're going to have a different weight. And I will tell you one thing, your I's and O's are critical, especially if you want to go into critical care. And I tell every new grad, every nurse that comes, the most important thing you will document is not your assessment. It is not that stupid mess that admin wants you to document, like, did you document your daily care? I don't care. The most important thing you will document is going to be I's and O's. And that is because in critical patients like this, a lot of the clinical decisions are going to be based off of a patient's I's and O's. Are they 4 or 5 liters positive? That's going to give you a different treatment than if they're euvolemic or even hypovolemic. So it is very important, even like floor nurse. If you're working in the hospital, and floor nurses are awful with this, they don't it'll have like no urine output for like a week on a patient. And they're like, unmeasured, but especially in your more critical patients, this is very important. Unmeasured is not going to cut it. Get in there and weigh those pads. On the national transplant waiting list, there's currently like 104,000 people waiting for some type of organ. And of those people, 87% are waiting on a kidney. So that's roughly anywhere from like 90 to 92,000 people are waiting for a kidney. And this is only going to include people waiting on a non-living donor. You're not going to be placed on the list looking for a living donor. Donors can be living. They can be someone who is officially brain dead and is still on a mechanical ventilator. They could be a deceased patient. The thing about kidneys, unlike, for example, for livers, you have to have a match you have to have like the whole compatibility workup done before you receive that organ. And both patients have to be in the same spot, which is pretty complicated. But with kidneys, it's a lot simpler. Unfortunately, there's just so many people on the list. With kidneys, we can keep them and preserve them outside of the body. And that's why we can take them from someone who has just died if we immediately take the right steps by cooling the organ and doing that whole gist of stuff that I know nothing about. But generally, it is best to get a kidney from a living donor, preferably someone who's related to you, who you have a more similar genetic makeup with. And that is going to help reduce the likelihood of your acute reactions as well as your chronic reactions. In fact, kidney transplants are not always going to be lifelong. On average, if you receive a kidney from a living donor, it will last from anywhere from 12 to 20 years. But if you receive one from a cadaver, a non-living patient, it is only going to have a life expectancy of 8 to 12 years. Do you see that difference? And your survival rate is higher with that of a living donor. It's like 95%, while that of a deceased patient is going to be 89%. So it's not, when trying to find that compatibility, they have to look at so many different factors. It's not just as simple as your blood type and whatnot as it is with donating blood. They have to do the whole human leukocyte antigen, and they have to look at all these other antigens to see if you are going to be compatible. And even then, rejection is still very common in terms of whether it's acute or chronic. And I'll get to that in the next slide. But patients who receive a kidney transplant are going to require lifelong immunosuppressants because you have that ability anywhere along the way to develop some type of rejection because you have something foreign in your body. I do know that the one time I think you don't have to have immunosuppressants is when you have identical twins, because they're going to have the same DNA, and you're not going to have that incompatibility there. Now, there's many things that we need to consider, kind of like with the whole triaging for patients with who are on the transplant list. They look at, how sick the patient is. They're going to look at the comorbidities. If you have a 8-year-old boy with cancer, stage 3, 4 cancer, then they're not going to give him a kidney. It doesn't matter there. You know what I'm saying? They're going to look at, let's do the greatest good for the greatest amount of people. So there's going to be a very, very complex system that they use to decide who should receive the organ. Patients who are going to have like advanced or untreated cardiac disease, any type of like active cancer, alcohol, drug dependency. Now, if you have a history of that, they are starting to allow you to receive kidneys, but you have to show that you are clean. Anyone who's going to have major infections such as hepatitis or HIV, even though I do know recently that they have been, I do remember reading something about a HIV patient who received an organ from another HIV patient. So I guess that does kind of make sense. If you have any like major coagulopathy or certain immune disorders like really bad rheumatoid heart disease or anything like that, if you're morbidly obese, if you have like uncontrolled diabetes or uncontrolled COPD, uncontrolled peptic ulcer disease, if they know you're not compliant. I do remember a guy, this was a few years ago when COVID started, he was going to receive a heart and he refused to get the COVID vaccine because they want to make sure at that time COVID was like killing everyone and they want to make sure that the organ is going to good use, and he was rejected from that organ because he refused that vaccine. You have to be up to date on your vaccines, you have to be compliant, and you have to show a will to do the things you need to do to survive, such as your immunosuppressants. If you're not someone who is going to be compliant, they are not going to give you an organ. Another thing is, a lot of times people who have like a lot of mental illness, like if you have severe schizophrenia or something like that, you're not going to receive it. You're not. Now, there are going to be three types of rejection. And the first one is going to be your hyperacute. And that you're going to notice that the patient has fever, hypertension, they're going to have a lot of pain and inflammation at their transplant site. And there's only one treatment for this, and that's going to be immediate removal of that kidney. There is no other way around this. Now, another type is going to be your acute rejection, and that's going to occur anywhere from like a week or two up to a few years. And you're going to notice that the kidney just isn't functioning appropriately. They may have oliguria, they may become anuric, they'll have like chronic fever at that time, hypertension, lethargy, and they may require dialysis for this temporarily, or could it be permanent? It is possible. Now, what they're going to do there is they're going to try to increase the dose of like the immunosuppressive medication and give supportive therapy such as the dialysis or whatever, and just hope that things turn around. Now, you're going to have that gradual or your chronic renal rejection, and that is just going to be a gradual decrease in the kidney function. So it'll be a very similar path with CKD. You're going to have like this chronic inflammation going on that is going to damage the nephrons, and ultimately you are going to go into a slower progressive type of renal failure until you reach end-stage renal. Obviously, they're just going to do conservative management. They'll do like, dietary restrictions, treat any underlying conditions like hypertension, diabetes, until dialysis is required. And I wanted to show y'all, did y'all know that when we get a kidney transplant, what they're going to do is they're going to just leave the old one in there too. So you're going to have like 3 kidneys. That's pretty cool, huh?